Hello, LibertyCon. One of the things that I have been invited to do is to continue the concept of the fireside chats on brain science. I am Dr. Robert Hampson. I am a neuroscientist. I'm actually a physiologist and pharmacologist, and I teach at the medical school for Wake Forest and do some research at Wake Forest Baptist Medical Center.
Hello, my name's Dr. Brent Roeder. I'm a recent graduate of the Wake Forest Neuroscience program. My research has been focusing on trying to figure out the stimulation approaches that we can use in a neural prosthetic to hopefully restore memory function in the cases of memory loss. So coming in and trying to come up with an assistive device for those who have already been injured.
Hey there, my name is Naomi Bean, and I'm a PhD candidate in the neuroscience program at Wake Forest. I work in a multisensory lab, and one branch of our research, the branch that I'm involved in, looks at a specific form of blindness called hemianopia. We have a multisensory rehabilitative paradigm that can restore visual function in those who have previously lost one side or one field of vision. So it's very exciting, pretty interesting work.
Hello, I'm Dr. Mitch O'Reilly. I'm also a graduate from the Wake Forest Department of Neuroscience. I actually did my undergrad work in athletic training sports medicine, where I completed a senior thesis on using, at that time, a newer cognitive testing paradigm in the return to play for college athletic football players. And so that kind of led me to the work in Dr. Hampson's lab and also similar to Brent's work of stimulation into hippocampus. But I've also worked in a different lab where we looked at more cognitive aspects of the brain and kind of mapping in a different area called the prefrontal cortex.
Hi, my name's Wohlrab. I currently am a warhaver for the Air Force, doing cool stuff. And then in addition to that, I'm still a medic in the Army National Guard. These days, mainly what I do is medical readiness defense and medic recertification for other medics in the Guard.
Hi, I'm Nick Rao. I'm a child psychiatrist, and I tend to focus a lot on kids I have a reason to see because there's something medical going on. So something I've been active in the past is working with kids who have undergone an acute trauma, who have a medical reason to be in the hospital, and even did some early research into which medication regimen might help the most with recovery and stabilization after an acute head injury in kids.
So our LibertyCon viewers will recognize some familiar faces and some new ones. Yes, I have heavily stacked the deck from Wake Forest. I am guilty. Yes, that's fine. I'll take that. So mostly what we're going to talk about tonight, or how we're going to structure this, is just a free panel discussion about what some of the causes are. Then we can talk about consequences, and then we can talk about rehabilitation from there. I think one of the things that I would like to do is have Doc Wohlrab start off with an experience of a combat injury, closed head injury that seemed not to be real serious at the time and showed evidence of being serious much later.
So back in 2000, let's see, which tour was this? 2010. We had, as part of a convoy escort team, we were back on our base that we normally operate out of. And so we were on some downtime. And while we were there, insurgents fired rockets into the base. And it was 3 rockets. One hit an open parking lot, another one, and that one detonated. One hit a truck that was moving past the parking lot and then failed to detonate, but it like ruptured the fuel. And so there were other issues going on there. And then the third rocket detonated against the T-wall, or the blast wall that was just outside of the gym. And it blew this blast wall into the gym, and one of my soldiers happened to be in the area where the blast wall was thrown into. He was just walking into the doorway to the aerobics room. So there were like, pieces of equipment for cardio, that kind of thing. And another soldier was on a little bike or something like that. Anyways, he had been picked up by the blast and thrown basically into into my soldier's lap, and had been torn up by the blast wall coming into the gym. And so Williams, essentially controlled the bleeding on this guy because he had been shredded from about the waist down on his backside. He managed to control the bleeding and evacuate this guy from the gym to the hospital, the combat support hospital, which was literally like a block and a half away. So he just picked him up and carried him over to the emergency room there. He was at the cache for a couple of hours, and he didn't exhibit any wounds, so he was told to go back to his living area. And I had during all of this, I was dealing with one of my soldiers who had come back from the gym and was like, hey, I was exposed to this blast, and so we took him over to the aid station and did our post-blast analysis to see whether or not he had suffered a concussion. It's called a military acute concussion exam, or MACE exam. And finished up, I had just gotten back into the LA, and another soldier had come and said, hey, Sergeant Wohlrab, can you come take a look at Williams? He's not acting right. I was like, okay. So I walked into his chew and he was looking at me. I could tell he recognized who I was. And I asked him, hey, what's going on? And he was all he could say to me was spaghetti. And so every question I would ask him, that would be the response I got. So it's like, all right, come on, you need to come with me. And we took him back down to the aid station. And obviously he had suffered concussion, and a rather serious concussion. And he was not allowed to go out on missions for a month due to that. That was the time it took for him to recuperate. Of course, he being the infantry guy that he was, decided about a week later to try and run the Army 10-miler. It passed out on the course, and our PA was just like, who's one of the coolest people I've ever worked for, but she was just reading him the riot act because she was running the 10-miler as well. And when she saw him on the side, she was just like, I told you, bed rest, what are you doing? And just proceeded to weigh into him. So, but yeah, that, he was unable to voice anything other than spaghetti for a couple of hours to us while we were working with him in the aid station.
Thanks. The reason why I wanted Doc to tell that story is because in many cases, when scientists talk about traumatic brain injury, they tend to downplay concussion. But concussion is a form of traumatic brain injury. Not only that, but the signs and symptoms don't show up right away. And so I want to just sort of toss this open for discussion at this point. If anybody wants to chime in on concussion and signs and symptoms, Dr. Nick.
Well, it's funny you say that scientists tend to downplay this, because the most common place where I see someone with a traumatic brain injury is in the ICU with a much more serious one. But the second most common place I see someone is in my office at an appointment, at a consultation, when they tell me that oftentimes a family member or another concerned party has said that things are changing for them. They are having some struggles with memory. They might be kind of making choices they wouldn't normally make. They might be irritable, and they're just not quite themselves anymore. And that's happening in young people. So I'm getting 30-year-olds coming into my office, 40 or 50-year-olds. And it's always when you pull it apart, there is a history of concussion, or perhaps even more scary to me is there's a history of subconcussive injury. And this is something that really worries me as a former boxer, because I've never been concussed, but I got hit in the face a lot by 200+ pound people. And I think that's probably the scariest thing about it, is that these things are subtle. They kind of creep in, and 20, 30 years down the road, you suddenly lack capacities that you used to have.
Yeah, we have, I was, unfortunately, another of my students was not able to join us tonight. He has been looking at issues with cumulative subconcussive injury. He is himself a former football player who is now looking at high school and college football players. And yet another student that was in a class of mine this spring is looking at hockey players. And one of the issues that she was telling me earlier is that the impact speeds and the impact forces on the ice can be higher than they are on the football field, which is very surprising. There's for the science side, they're now starting to equip a lot of players with sensors in helmets, but the helmets can move around and they can jiggle back and forth, so you don't necessarily get an accurate reading. Now what they're trying to work on is mouth guards with accelerometers in them that will not only get the head movement, but they'll also get the jaw clench that occurs with a concussive impact as well. So that's actually fairly frightening. I know that you worked with that some, Mitch, as well. You were looking at sports injuries.
Yes, you mentioned the two biggest sports that concussions occur in: ice hockey for men and American football for men, followed by rugby and association football or soccer. Those are your four big areas. And in fact, what should be a little bit, I don't want to say too concerning, but something to take note of, we also see that the incident per sport is higher for women, especially in ice hockey and soccer, than it is in men. And so, I also want to point out, one of the biggest issues with concussions is the unawareness or the not willingness to report. And that's really huge in sports like college football, where you may have someone who suffered a concussion, but they want to get back in and play. So they're not going to report everything as accurately for fear of them being pulled out. And so that is one of the big issues that I saw or that I've heard was pretty much, you want to make sure that everyone is trying to tell you the truth. And sadly, you almost have to assume somewhat that they may lie to you just to get back out onto the field. And so that's why one of the things for my senior thesis was looking at, can we get something more objective than symptoms that are being reported to you so that they can get back out there? Now, granted, whenever you're at the high level like the NFL, you have a little bit better you have better coverage and better return to play systems like their new concussion protocol. But when you look at how many people play in the NFL versus college versus high school, that's not covering the most amount of people. And just like Dr. Nick was talking about, you end up having this history of subconcussive or even concussive effects that just continue on. And that's where they're occurring in high school and perhaps in college. And that's really the big emphasis I want to put out there, is that that's really where I think a lot of focus needs to be at for preventative measures.
One thing I want to add to that is you also have the pipeline for sports starting at a younger and younger age. So you have middle schoolers and high schoolers that are in competitive sports. So, for example, soccer, where you're not going to have the helmet, you're not going to have a mouth guard. Imagine, a little 8-year-old running around trying to head the ball repeatedly. And, what's that going to be doing to their brain at that young of an age?
Well, and where I grew up, we had not just touch football, but full tackle football in elementary school. And yeah, sure, you have the helmets and stuff, but this is like the 1980s, 1990s. So those kids would, we would beat each other up. So I don't know that that's necessarily a new phenomenon. It's, it's certainly been out there. I guess the question then is, how long have they actually been looking at it?
I accidentally knocked a kid out in practice for middle school flag football.
Yeah, because from the military's perspective, concussions, we really didn't start taking them really seriously till like 2009, 2010. Like my first tour in Iraq in 2010, they were just rolling out the MACE exams to us as we were deploying. I had not seen it until I was going in theater. And I graduated the combat medic school at Fort Sam in 2008. We didn't have them then, so it's interesting to see how people took that seriously going forward.
That's around 2008, 2009. That's whenever I was doing my thesis and trying to research a history of concussion. It was quite difficult because there wasn't that breadth of research that there is now on it. So I'm not surprised that you're pointing out right that point is whenever military and other sports started really taking it seriously.
I think there's also another factor at play is that we've seen over the decades that sports performance and also body size have actually increased pretty drastically over just 30 or 40 years. So if you talk about like sub 5 second 40-yard dashes in football, way more people run that now than even in 1990. And when you talk about 300, 400 pounders on the field, if you talk about the size of a linebacker, every position is 30 to 50 pounds heavier than it was just 30 years ago. So people are hitting with more force than they were back then as well.
Well, also sample size for data privacy. Back when I was doing my master's 6 years ago at USC, they had concluded a study on the USC football team where they actually had to buy an extra large scanner to fit in all the football players. And they bought it specifically for the football team to make sure they weren't killing their brains. And they had figured out risk levels based off of the different positions. But they still can't release any of that data because they don't have a large enough sample size to be able to release it without people being able to piece it together to figure out who had what injuries and what their private health information is. And it's been 6 years since they completed it.
Yeah, it's interesting when everybody was mentioning their concussion experiences. I go all the way back to 4th grade. I was playing kickball, organized recess in 4th grade, and I was running from first to second base and ran right into the player, and we hit our heads. We hit forehead to forehead, and that was I fell down and was blank for about 10 seconds. So I've been told. My best friend just sort of shook it off and said, "Man, you have hard head." And then sort of that gave me a new nickname for the remainder of 4th grade until I moved, which was a good thing. But it's a frightening thing when you're a parent looking at what some of the injuries are. And when you have soccer coaches that are trying to encourage your kids to head the ball, and the neuroscientist in you is saying, no, 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 they're too young for this. They're too young for this. So, so what are some of the signs and symptoms that we're looking for? What are some of the brain areas affected? I think, Doc, the story you gave is one that's pretty clear: aphasia, the inability to speak. It doesn't have to necessarily be not able to speak so much as abnormalities in speech. What are some of the other things that we can see as a consequence of concussion, subconcussive injuries, or even accumulating concussive injuries. I'm just sort of tossing this out there.
Well, one that's of special interest to me, because I'm working to develop a memory prosthetic, is degradation of memory. So being able to form new memories, being able to recall memories. Another thing is shrinking how many items you can keep in your working memory, how long you can keep things in your working memory. So that's a big one and you see that a lot, not just with like a single major traumatic brain injury, but you see that also with a lot of repeated moderate brain injuries too.
Right. Well, that was the thing that we looked for with the MACE, is the short-term memory recall. And then, so you'd ask them a series of questions, repeat these things back to me. And then, a couple minutes later, you'd ask them to, repeat back what I had asked you previously. Of course, the problem with that was, with that exam that we had a series of word association, or words that we had to use, and then there were 2 or 3 alternates. And so if you had to keep using this exam on the same people, they would just memorize the words. Supposedly they fixed that since I was administrating them, but I haven't seen a new one on that yet.
One of the things we had to do when we were first designing a memory test for our humans, we had been applying memory tests in animal models in the laboratory. And if you show an image and then you have an animal respond and pick that image out of a list a couple, about a minute later, there is a definite amount of forgetting that takes place that is proportional to the amount of time elapsed. In a human, if you show them a picture, they can remember it for a long time. And so one of the things that we had to do with the developing a memory test was, in fact, to say, okay, we're not going to give you a recognizable picture that you can put a word to, so it's not, you're not showing them a tree, you're not showing them clouds. Let's see, I'm trying to point to the clouds, it's not working. Point to the clouds. You're not showing them pictures that you can put a word to. We were showing abstract color block patterns, because when you can put a word to it, you remember better. When you can't put a word to it and you have to find some other way to describe it, or you have to use way too many words to describe it, then it's much harder to remember. On the other hand, one of the things you can do in terms of a concussion test or a memory test is when the individuals have difficulty putting a word with a picture. So that's one of the tests that gets performed on a lot of patients with in the neuro clinics, is they'll do a series of neuropsychological exams, one of which is word association. If you see a picture of a bicycle, can you actually name it as a bicycle? And that's something that we see degrades with head injury, and it also degrades with Alzheimer's disease. But what are some of the other brain areas? Naomi, you've been really quiet, and I'm not going to let you be really quiet here. But I know that hemianopia can occur with brain injury. So why don't you tell us a little bit about what that is and what some of the conditions are with that?
Sure, absolutely. So I absolutely can talk all day. So I was going to let you guys go with concussion, and then I was going to take over the rest, right? That was my deal. So yes, with hemianopia, for our blindness that we study, it's damage usually to the visual cortex, one side of the brain, or one hemisphere of visual cortex. Now that's sort of the top part of the brain, is sort of the way to think about that. Our top 3 players for hemianopia are stroke, tumor, and TBI. we're mostly concerned with stroke, but TBI is certainly a factor. And so when we see any sort of damage or loss of tissue in visual cortex, we achieve hemianopia. So it is certainly possible with concussion to see a blindness, albeit it may be temporary, but it is certainly possible to see it.
Taking that a little bit further, what's the most, why don't you give us a little bit more of a description of how hemianopia actually presents? I mean, what?
Absolutely, sure. So because the damage is on one hemisphere or one side of the brain, we see a loss of visual function in one side of space. And that sounds really striking. And for us as researchers, that is very striking. Interestingly, for a patient, though, it may not be something that they're consciously aware of. And that sounds really weird, right? And what a strange experience that must be. With something like TBI or stroke, the outcome, the manifestation for the patient may be a little more striking. With something like cancer or tumor, something that compresses, like the optic nerve, for example, or parts of visual cortex tissue, it may be more subtle. Essentially, what the patient would experience, if I can say that, is a narrowing of the visual field. And so the amount of space they're able to respond to decreases. And so again, they may not even be aware that they no longer have vision to the extent that they used to. And so that creates a really dangerous situation, especially if the person hasn't been identified as having hemianopia. They may be trying to navigate their environment. They may be trying to drive. And clearly with a narrowing of the visual field, that's a very dangerous situation to be in.
One of the most striking examples would basically be if you look at your visual field and to realize that everything from here on over is gone. And yes. and as Naomi has said, and it's not so much that the person says, okay, half my visual field is gone, because their brain is telling them that, it's all the visual field that I can give you is everything from here over here. Yeah. This is all I know about. Right. It also leads to another type of not so much an amnesia, but as what we would call an agnosia, which is basically Latin for I don't know. But it's what we would call neglect, which is visual neglect, and not being able to recognize things in the visual field, even though they are. I'm actually going to circle back in a little bit to some of the rehabilitation indications with visual defects, and some really neat research that Naomi's lab has been involved with. Absolutely. But these visual defects are another one. Hearing defects. We can. I think one of the more insidious hearing defects that can occur with repeated subconcussive injury is ringing in the ears, tinnitus. It's not just too many loud rock concerts. It can be, wear earplugs to the Cruise Shadows concert, everybody.
Well, and Dr. Hampson, I think that is, it's sort of an interesting point that you're bringing up, because like with my field of study and like with what we're looking at a very specific injury to a very specific area, right? Visual cortex on one hemisphere. But the thing I think that is so jarring about concussion and everything that you guys are really focusing on is that not only could it happen anywhere, it's maybe happening everywhere. If you're talking about soccer injuries, or you're talking about blast injuries or whatnot, you can't really predict very well, or maybe you can. Maybe some of you guys can help me with this, with football studies. I don't know. It just seems very jarring to me that is, it's not really random, but it's almost random.
Well, you have the coup contra coup injuries. You get hit in one place and your brain's going to slosh and bounce off the back of your skull on the other side. So quite often you have at least one other injury from getting hit.
Yeah, and then you talk about like the pressure wave moving through, say, like armor, and it'll go through the armor, travel to the other side of the vehicle, get trapped by the armor plate on that side, bounce, and then you're just sitting in a chamber where it's sort of bouncing back and forth. Or, for example, like a bunker or something like that. When the Iranians launched those IRBMs or ballistic missiles at the bases in Iraq, not last January, but the previous January, all the guys had time to get to the bunkers. Like they knew for a while that this was going to happen, but that didn't stop the concussion injuries from very large warheads going off on the base. Sure, nobody died, but it wasn't that nobody was injured. They were injured, but it was concussive injury. If you go back to something like World War II, where you're talking about large scale bombardments, where you're talking about armored warships fighting each other, some of the injuries that you would see there, some of the deaths you would see there were concussive death, as opposed, so it'd be somebody who would be killed by the concussion wave of the artillery round or the naval gun round, and not have a mark on them. And that was very disconcerting, both like in World War I, World War II, for people to come across that, because they, at that time, they just didn't understand how did these people die, and it's a concern that we're going to have going forward, as we talk about peer, near peer conflict. So if we have to fight, someone's like Russia or somebody like China, where now you're talking about militaries that are as capable as ours, that have long range artillery and ballistic missiles and all this other stuff, we're going to see those types of injuries again. It's not going to just be the random blast injury for like 3 or 4 personnel. It could be, an entire unit has been under like sustained artillery fire for a while. And then, you start seeing stuff like the injuries like, I don't know if people have seen videos of the French soldiers from World War I. They did a study on them that, had been under sustained artillery fire for a very long time, and the defects that they had. We may start seeing injuries like that again on the military side.
You bring up an interesting point, and that is the fact that so often we think of concussion from direct impact. And in reality, the whole point of what causes concussion, I mean, Brent also got into this as well, is that the brain is in a fluid environment in a hard container, and it's free to slosh back and forth. So a large component of concussion is a movement component. It's a sudden movement component, and it does not require direct impact to get that sudden movement component. You can actually get that from a pressure wave that is passing. And when Doc's talking about the overpressure wave from a bombardment or the shock wave entering the compartment of a vehicle, and as the shock wave goes through one side, its frequency has changed. And so its frequency has changed so that instead of passing through the other side, it bounces back. In much the same way, a car in the direct sun will heat up because the sunlight is frequency shifted down into the infrared and will then heat up your car. Well, the same thing happens with sound and with pressure waves. And again, you get the movement back and forth, and you get a sudden movement back and forth.
One odd thing that from fencing years ago, I noticed that people that tended to wear their fencing masks more snugly tended to get their bell rung harder when hit in the face, but on an off axis. So I'd always wear my mask as loose as I could where it would be on. So I'd get hit in the head, let's say on the side of the mask, and my mask would rotate halfway around my head. And I actually almost broke my nose that way one time because it got hit hard enough. And I gave myself a few bloody noses. But on the other hand, I'd get a bloody nose, it would look bad, but someone else would have it and they'd have their mask on tight and they'd get clocked in the side of the head and they'd be spun halfway around. And they'd just be following their head around. And this is just from fencing. I mean, you know, it's not like you're getting hit by a linebacker.
This is not an academic comment at all, but rugby players insist that football players get more head injuries because they wear helmets. And I think there's a couple of components to why they say that, but I'm actually not sure if that's supported in the evidence or not.
I've argued that the problem is shoulder pads. That the improvement in shoulder pads has exceeded the improvement in helmets. So what we need to do is keep improving the helmets, but make the shoulder pads less effective. So they're less likely to lead with the shoulder.
Yeah, and then the other thing I've heard about is the threshold hypothesis that with football, like most of your hits don't hurt because of the pads. It's only the really big tackles that hurt. Whereas in rugby, everything hurts. So everybody's always compensating a little bit. Whereas in football, they become kind of fearless and they stop using their necks and stop using their core to stabilize. So
There's definitely more American football concussions than there are rugby in the United States. However, that doesn't necessarily mean that there's more per person, per team, because there's fewer people playing rugby than there are American football, especially in high schools and such like that. So you have a point. I think it goes back to kind of, again, you can make an argument that the improvement in helmets have definitely improved because you're definitely adding more stress onto the helmet rather than to the head. But with them being so snug, kind of what Brent was talking about, it feels like you're still passing along that force to the head rather than kind of having like an airbag kind of to just caution over, to absorb that impact. And I think that has to be the next big step with helmets for something to absorb that force rather than pass it along to the head.
It's actually something you see in bicycle helmets. Bicycle helmets now have that closed cell foam lining instead of just having little foam standoffs that cause the helmet to stand away from the head. The student who is doing the study with the hockey players had commented in a presentation to my class that the accelerometer readings from the helmets were not very accurate. And when they did some comparisons between a mouthpiece accelerometer and a helmet accelerometer, they were finding that they were underestimating the actual impacts. And it's partly because the helmet's moving.
I am reminded that this is a sci-fi con, and actually was just reading a book about that, and now I'm reflecting on the fact that lots and lots of books actually talk about this phenomenon. They talk about solutions to this phenomenon in the sci-fi world, like gels and media that can even fill up a fighter pilot's ship so that if there is an impact or an explosion of some kind, that they can be cushioned by a medium that's much, much more dense than air.
The Judge Dredd film in the cars.
Oh, yeah.
Demolition Man, where he goes off the side and
oh yeah, that's right. It's Demolition Man. I'm sorry.
Yep.
Oh, okay.
It's the same. It's almost practically the same cast in either movie. So
I was actually thinking of the Forever War, where in order to sustain the accelerations, all of the soldiers got plugged up to a high pressure system to actually pressurize their bodies to increase their internal pressure so that they would then be surrounded by a fluid that could impact. Yeah, that's a very sci-fi way to go.
Well, Tony Stark would turn himself into a vegetable the first time he did one of those super fast drop down
Boom!
hero pose on one knee thing. His heat stopped, his brain would keep going and kind of splatter on the bottom of his skull.
Needs an arc reactor for the stasis field to stabilize his brain.
Well,
Yeah.
but I think when it comes to talking about helmets and everything, it's a question of what are you trying to protect for. So like with my example of a fencing mask, it's not trying to protect you against blunt force trauma. It's not trying to protect you against TBI. It's trying to protect you against one thing: not getting stabbed in the face. They're really, really, really good at keeping you from getting stabbed in the face. And that's it. I mean, I appreciate that. I never got stabbed in the face.
Yeah, the Army is looking at, over the 20 years of the GWAT, was looking at different helmet designs to help mitigate IEDs. But at the end of the day, we're still wearing the same ACHs because, you're still, the major concern obviously is penetrating injuries from GSW. So are our helmets going to change? Don't know. As we go back into large scale combat operations preparation, that kind of thing, where's the emphasis going to go in terms of like body armor, that kind of thing? Because the other thing is, during the GWAT, we were wearing increasingly more and more amounts of body armor, but we were also more and more stationary inside vehicles. When you go to something like fighting in Europe, you don't have the luxury of going everywhere in a vehicle. We're probably gonna see something like less and less weight in terms of at least the armor aspect. So how the design of our helmets and that kind of thing is gonna change over the years will be interesting to watch.
Well, I also wonder if, like back in World War I, where you have a lot of overhead concussion waves, I wonder if something like the Brody helmet, the saucer one, would actually be better in dealing with blast waves, at least from overhead, than a modern one might be.
Possibility.
Something that actually I can throw into this concussion discussion with helmets and basically preventative is a line of research that we are pursuing in our lab, again related to specifically hemianopia, but along the lines of what you guys are talking about. We see with cortical damage that we look at secondary damage, which is sort of what you guys are talking about and sort of not what you're talking about. You guys are talking about like a physical damage that occurs. Brent has specifically pulled that out, secondary physical damage. But even with what we look at a almost like neurochemical damage that occurs, or what we would call like an excitotoxicity. Which is like a release of calcium that can damage other structures in the brain, other areas in the brain that aren't necessarily the area of impact, if you will. And so what we're looking at is a pre-treatment or a post-treatment where you can actually give a treatment to a patient, presumably before, we're looking at that right now, or shortly after an injury, and it will bind to receptors in other areas and prevent secondary damage. So I wonder too how much we might move away from this idea of helmets and more towards something like neuroprotective in that manner.
Ooh, I want to jump in because this actually dovetails into the area I've got a pilot project I'm working on right now. It's interesting you bring that up because that's absolutely correct. We have a first injury, which is physical, and then we have a second injury, which is chemical. And there's actually a couple things I'm going to rant about. Please feel free to cut me off. Before I took care of kids, I studied to be an evolutionary biologist, specifically with small monkeys, which are actually a lot like kids, just a little less hairy. But evolution is great, except when certain parameters aren't met. And some of those parameters being the difference that evolution creates has to lead to the organism having more offspring. So we are very good at healing skin wounds because skin wounds are really easy to recover from. We're very bad at healing bone wounds, for example, because if I break my leg, I'm not going to be alive in 6 weeks in the wild, right? I'm dead. It's over, right? And the fact that we do have some evidence that wolves and great apes and some other animals can survive broken bones shows us sort of the importance of social functioning. But there I go off on a tangent. So I'm going to pull it back. And brains are actually a great example of why we why healing sucks for brains, right? Is because, right, anything that hurts my brain enough to leave me incapacitated, first of all, that injury was probably caused by something trying to kill and or eat me. And second of all, I'm going to be incapacitated long enough for it to succeed. So it doesn't matter how well my brain can heal over the next month if I'm busy being eaten right now while I'm passed out from a head injury. And so excitotoxicity is probably a leftover evolutionary adaptation from our brain's germ adaptations as originally rather skin cell-like. So it's a technique that probably works great for things like scar formation, right? Where you want scars, where you want something big that covers up a gaping wound, but you don't want a scar in the middle of electrical tissue in your head. And you know, it's great that you brought that up, the secondary injury part, because one of the things I got really, I throw giant hissy fits whenever I discover a problem in psychiatry that no one's really addressed in the 100 years our specialties existed. Turns out there's a lot of them, but no one likes me and I don't have grants, so I'm not going to solve any of them anytime soon. But what I found was that I had all these kids coming in with traumatic brain injuries or other sort of brain injuries, and there had actually been almost no work into what can we do to prevent secondary injury. And so that's actually an area where I was focused on, is like, I can't do anything about the dead brain cells, but maybe I can prevent more brain cells. So yeah, sorry, rant over.
Well, it's not so much a proactive, but a reactive for secondary injury is increasing use of craniotomy, where they'll just pop off a major chunk of skull before they even have an indication that it's needed, because it might be, or it's more likely to be needed. And that way, you, especially with swelling, gives the brain plenty of room to swell, because you know there are benefits to actually swelling at times. But let the brain do its thing without getting squashed.
Interesting that we've taken the tangent to excitotoxicity, which is quite relevant. A friend of mine from back in my grad school and postdoc days was working with excitotoxicity, and one of the things he noticed was that in the case of ischemia, stroke, and a compressive injury in which there is reduced blood flow, is that the damage is not done when the blood flow is reduced. A lot of the damage is done when the blood flow is restored indiscriminately. And it's the same principle as how you warm an extremity from frostbite. Because if you warm the surface and the core is not warmed, or if you warm a midpoint and not in a manner that will restore blood flow equally and uniformly and appropriately, then you still get a fair amount of damage because of that time period when the tissue is frozen. It's really not degrading, but once there's blood flow again, or once there's not blood flow but the tissue is warmed up, yes, it's degrading. So it's an interesting issue. I'd like to talk a little bit about rehab possibilities. Where are we as a medical science with rehabilitation? And Nick is laughing because he's going to say we're not, and but that's okay. And the reason I ask this is there is a very famous case of a railroad foreman who suffered an injury right through his frontal cortex. The name is Phineas Gage, and since this is a LibertyCon audience, they've heard me talk about Phineas Gage before. So the important part is that Phineas Gage suffered an iron bar passing, entered in right around the eye socket, came out the top. The frontal lobe was pierced. For the most part, what we actually saw was a compressive injury in that the tissue was forced apart and compressed to the sides. Gage walked off. He walked to an aid wagon on his own. He was conscious, he was talking, and he did recover a fair amount of function. He was down in South America and was a drover, drove a multi-horse team on freight runs, running a freight carriage. And that is something that required fine motor skill and a lot of cognitive ability, which is something, and required discipline, which is something that the common report said he lacked after his injury. But apparently that wasn't necessarily the case, and he was able to rehabilitate. So where are we looking in terms of rehabilitation from a brain injury?
Well, Phineas Gage got his injury in Proctorsville, Vermont, which is where I grew up. So I'm going to call first on this. I call seniority. I will say, well, one of the things, I think there's a couple of things to note about this. You know, from my personal experience, education, all of that, a lot of neuroscience seems to be based on these stories like Phineas, where you have damage to a specific area. And then we sort of make this conclusion that that's what that area does. Whatever deficit behaviorally the person shows, we say, oh, this is what that area does. But I'm not ashamed to say that sometimes we're wrong when we make those assumptions or those correlations. And I think that's part of the challenge, is not knowing exactly what everything is doing in the brain and where all of our capabilities are housed. I will say for my work in vision, even this rehabilitative process that we look at almost came by mistake or surprise. So one of the original people looking at this, his name was Sprague, and he was doing visual cortex. He was looking at lesions of visual cortex, this comprehensive damage. And he actually lesioned another area of the brain, thinking that this was going to further the visual deficit. It was another, what we would refer to as a subcortical visual structure. And much to everyone's surprise, damaging this second area actually increased visual function in yeah, I see a couple of nods, right? This is a cool story. It increased the visual function in his participants. So I think that's part of it, right? There are results that we expect, and we travel down these roads of discovery and find that our outcomes are not necessarily what they thought they were going to be. So I'm going to pause and let anybody else jump in. But
well, I think one question is, how long did they actually observe Phineas Gage? Because you talk about some of these things, mood or behavior changes, that's a sign of concussion. You know, if he's having trouble focusing on things, that can be a sign of concussion. So if they're only, and he had a pretty darn severe injury. I mean, when you consider a giant iron rod getting shot through your brain, you're going to have a concussion. It's going to be pretty bad. So were they just observing him during the time that, forget everything else, he just had the concussion, and they were like, oh, well, okay, this is him now?
So Brent, I think you hit on one of the key pieces of sort of like questions here, and I think this is something Doc can speak to as well, is like, okay, something really bad happened to you, and now you're acting different. Well, okay, there's a lot of reasons for that, right? Like you mentioned, concussion, acute recovery, PTSD, right? And then TBI, right? And I'm really interested in that difference between PTSD and TBI, because unfortunately, that's the situation of a lot of my kids. That's the situation of a lot of our veterans, right? And how much of what we're blaming PTSD on is really about TBI and CTE.
Well, and Phineas Gage, because his job was actually, he had a trusted job. So he just lost his job. He had no source of income after this. You know, people were treating him, I'm sure people were treating him weird. How much of him going to be, you know, assume you had no injury, you got fired from your job, said you can't ever get this job again, and everyone starts treating you like you're a weirdo.
Yeah.
You know, how polite and pleasant are you going to be just from that?
Yeah.
One thing I don't want to forget about is that we did touch on late effects of traumatic brain injuries before. And so I got like super obsessed with Phineas Gage like a month ago. I don't know why, but one thing I discovered was he was pretty young when he seems to have developed sort of a terminal dementia. I think only about 10 years after his accident, which would have left him in his late 30s. But it's this, and coming back to the sort of neuro rehab and maybe even excitotoxicity, this is what we see, is we see brains adapt, we see that maybe they don't do quite as well at the task as when the original specialized brain structure was involved. But then we see 10, 15, 20 years later that it's almost like that brain was overtaxed and it's just burning out like a hot rod engine run too long.
It's definitely going to be interesting for, again, if we do return back to something like large scale combat operations, are we going to see the kinds of, or what kind of long-term effects are we going to see in the veteran community from that? Is it going to be something along the lines of what we saw in World War I, World War II veterans? My own granddad, World War II vet, did D-Day, the whole European theater. But later in life, was diagnosed with Parkinson's, and then not Lou Gehrig's disease, but something close to it. How much of that was just repeated exposure to, the fact that he was under V2 fire at one point, because they were trying to blow up the bridges over the Rhine, the Germans were. So they were firing like literally everything they had in their inventory, and his unit was just happened to be up underneath that. So what's the association between this number of concussive events and what the neurological defects that you develop later in life? Because I don't think anybody attributed that, at the time, it's the 1990s, early 2000s. It was just, well, you're getting older and this is what's happening to you.
Well, and there's been some indication that history of TBI can lead to earlier onset of Alzheimer's symptoms. So is it just that on top of the Alzheimer's, they've lost a reserve capacity, so to speak, that would have helped them compensate for the Alzheimer's symptoms that was lost due to the TBI. So the Alzheimer's started at the same time, but you don't have the ability to compensate for it like someone else might.
It's worth noting that CTE is also a tauopathy. So tau protein is involved in a lot of dementia processes. I'm not going to talk too much about this. I'd like someone else to, because I work with kids, but tau is involved in Alzheimer's. It's also involved in chronic traumatic encephalopathy as well.
Yeah. We're actually running fairly close to our time. So CTE can be next year's Fireside Chat, because actually I think that is a fascinating thing to cover. I want to thank everybody. I really do. I think we have a little bit of a legacy with LibertyCon of giving them some real science in their science track. And it is always great to get a group like this together and just chat for the audience. I wish we had an opportunity to take questions. That's kind of why I went with a little bit bigger group and just go round and round on this. And we're essentially asking and answering each other's questions. But on behalf of LibertyCon's programming, I would like to thank everybody for participating, and next year in person.